Imagine this. One moment you're standing, completely present, and the next, well, the world just goes black. Then just as suddenly, you're back. Maybe a bit disoriented, but often feeling completely fine. It's quite an arresting experience, isn't it?
It really is.
Whether you felt it yourself or maybe seen it happen to someone else, that sudden loss of consciousness, but then, boom, spontaneous recovery.
Exactly. And today, that's what we're diving into. The medical term is syncope, but most people just call it a blackout or fainting, a transient loss of consciousness.
Right.
Our mission, really, is to try and navigate this sometimes pretty complex landscape of why people black out. We want to pull out the key insights from our sources to help you understand what's actually happening when your body just briefly shuts down.
And it's surprisingly common, actually. I was looking at the figures. Our sources say it accounts for, what, up to 2% of all emergency department visits?
That's right. And even up to maybe 6% of hospital admissions in some studies.
Wow. But the crucial thing, as you said, is that while a lot of these are, well, harmless.
Benign,
right. How serious it is completely depends on the underlying cause. That's the key difference we need to explore.
Absolutely. So let's unpack the basic mechanism first. At its heart, any blackout, doesn't matter the cause, it results from a temporary inadequacy of blood flow to the brain.
Okay.
Cerebral nutrient flow, technically. Most often, this is triggered by a sudden drop in your body's overall blood pressure. It just falls below the minimum level needed to keep the brain working properly.
So essentially, the brain isn't getting enough fuel for a moment. And the most common reason for that is something called neurally mediated reflex syncope. Sounds complicated.
It sounds complex, but it's really about your nervous system sort of overreacting or reacting in an unexpected way.
Okay.
And within that big category, the most common type, the one most people probably think of when they hear fainting, is vasovagal syncope.
The common faint.
Exactly, the common faint. And the hallmark here is usually a slow, progressive prodrome.
Prodrome, meaning warning signs.
Yes, warning signs, like you might start feeling dizzy, maybe a bit nauseous. You might notice your skin getting pale or start sweating, or your vision might dim just before you actually black out.
And the triggers for that?
Oh, common things. Like getting blood drawn phlebotomy, or just standing still for too long, especially somewhere warm. Even intense fear or emotional stress can set it off.
Okay, that makes sense. Now here's one that sounds a bit more unusual. Carotid sinus syndrome. Still under that reflex umbrella?
Still under the reflex umbrella, yes. This one involves a hypersensitivity of the carotid sinus baroreceptor.
Which is a pressure sensor in your neck.
That's the one. It's a pressure sensor in the carotid artery in your neck.
Wow.
And if it's hypersensitive, it can cause an exaggerated response when stimulated, leading to either a very slow heart rate bradycardia or your blood vessels suddenly widening vasodilation, or sometimes both. And that drops your blood pressure.
Okay.
You'd suspect this particularly if the blackout happens, say, while turning your head sharply to one side, especially in men over 50.
Really? That's specific.
It can be. Or sometimes people feel faint, get that pre-syncope feeling when they're shaving over that area or maybe wearing a really tight collar.
Interesting. And then there's situational syncope, another reflex one.
Yep, another reflex type. This is a response to a specific physical stimulus, like straining.
Straining how?
Like straining during urination, that's called micturition, syncope, or defecation.
Well,
Even a really forceful cough or sometimes swallowing can trigger it in susceptible people. It's the body overreacting again.
so for these sort of reflex faints, our sources mention something called the 3 Ps to help spot an uncomplicated one.
Ah, yes, the 3 Ps. They're quite helpful. First P is posture. Did the blackout happen after you'd been standing for a long time? Or, crucially, could it have been prevented if you'd just laid down?
Okay.
Second P is provoking factors. Was there a clear trigger, like pain or seeing blood or a medical procedure?
Right.
And the third P is prodromal symptoms. Did you get those warning signs we talked about? The sweating, feeling unwell, dizziness beforehand?
And if all 3 are present?
If all 3 Ps line up, it strongly suggests it was a benign, uncomplicated, faint, likely vasovagal.
Got it. So we've talked about body reflexes causing a temporary shutdown, but what about something maybe simpler, like just standing up too quickly? That brings us to orthostatic hypotension, right?
Exactly. Orthostatic hypotension is precisely that. A significant drop in blood pressure, specifically when you go from sitting or lying down to standing up.
And how much of a drop are we talking?
Well, the definition is pretty specific. It's a fall in your systolic pressure, the top number, by at least 20 points, or 30 if you already have hypertension.
Okay.
And or a fall in your diastolic pressure, the bottom number, by at least 10 points. And this happens within about 3 minutes of standing.
And what causes that? Is it just being dehydrated?
Dehydration or decreased intravascular volume is definitely a common cause, but it's not the only one. It can also be due to poor vascular tone. Your blood vessels just aren't squeezing properly when you stand up.
Oh.
Medication side effects are a really, really frequent culprit here.
Like what kind of meds?
Oh, things like diuretics, certain blood pressure pills like beta blockers or calcium channel blockers, even some older types of antidepressants.
Mm-hmm.
Also, being on prolonged bed rest can do it. And certain diseases that affect the peripheral nerves, think diabetes, Parkinson's disease, Lewy body dementia, they can all interfere with the body's ability to regulate blood pressure when standing.
And when are the symptoms usually worse?
Often worse first thing in the morning, or in hot weather, sometimes after meals, or if you've been standing still for a while, and even after exercise sometimes.
Okay. Now, let's shift gears to the one that sounds more worrying. Cardiac syncope.
Yes. This is the one that really demands attention.
Because it often presents suddenly, right, critically, without those warning signs we talked about.
That's a major red flag. Sudden onset, no prodrome. While a common faint is usually, an inconvenience, cardiac syncope can be a sign of a serious underlying heart problem. That suddenness is the body basically screaming for help.
What are other red flags for a cardiac cause?
Big ones include blacking out during physical exertion. That's never normal. Also feeling palpitations, like your heart is racing or skipping beats right before you lose consciousness.
Okay.
A family history is really important too, specifically. Sudden cardiac death in a close relative younger than 40, or if there's a known inherited heart condition in the family.
Anything else?
Yeah, new or unexplained shortness of breath, any fluid retention like swollen ankles or just significant fatigue, these could point towards underlying heart failure, which can also cause syncope.
And it's fascinating, isn't it, how many different heart issues can actually cause this? It's not just one thing.
Not at all. It's a whole range. It can be heart rhythm problems, arrhythmias, either the heart beating way too fast.
Like ventricular tachycardia?
Exactly. Or things like torsades de pointe, supraventricular tachycardia,
Yeah.
or the heart beating too slow, bradycardias, heart block.
Okay.
But it can also be structural problems with the heart itself, like hypertrophic cardiomyopathy. That's where the heart muscle gets too thick. Or aortic stenosis, where the main valve leaving the heart is narrowed. Even a heart attack or a pulmonary embolism, a blood clot in the lungs, can present with syncope.
So a wide range of potentially serious causes there. Now, what about neurological syncope? Our sources suggest this is often a case of mistaken identity.
Yeah, that's largely true. True neurological issues are actually quite rare as the primary cause of a simple blackout. If a brain problem is severe enough to cause loss of consciousness like that, you'd usually expect other signs.
Like what?
Like persistent neurological problems afterwards, or a significantly altered mental state. For example, if it was due to reduced blood flow to the brainstem.
The part controlling vital functions.
Right. Then the person might also report other things like double vision diplopia or vertigo or maybe weakness or numbness somewhere, specific focal deficits. Not just a blackout and quick recovery.
So if it's often mistaken, what's the main thing it gets confused with? And how do doctors tell them apart?
The number one condition mistaken for syncope is actually a seizure. Now, confusingly, you can sometimes get brief, jerky movements even with a simple faint, especially as blood flow returns to the brain.
Right, that makes it tricky.
It does. But key pointers towards a seizure would be things like significant confusion after the event, what's called a post-ictal state, biting the tongue, especially the side of the tongue, incontinence, losing control of your bladder or bowels, having an epileptic aura beforehand, like a strange smell or visual disturbance, or the head turning strongly to one side during the event.
Any other clues for seizure?
Yeah, sometimes prodromal feelings like déjà vu, feeling like you've been there before, or jamais vu, feeling like something familiar is suddenly strange, unusual body posturing during the event, or limb jerking that's quite prolonged are also more suggestive of epilepsy than syncope.
Okay, so bringing this back to you, the listener, you've had a blackout, you've recovered, you feel okay now. How do doctors actually figure out what happened? What's that initial detective work like?
Well, this is where the history, just talking to the patient, is absolutely paramount. It often gives you most of the clues.
So what kind of questions are crucial?
You need to ask, What exactly were you doing right before it happened? What led up to it? How long do you think you were unconscious? Did you have any other symptoms at the time? Chest pain, shortness of breath, palpitations?
Okay.
What position were you in? Standing, sitting, lying down? Were there predisposing factors like being in a hot, crowded place? And importantly, how did you feel immediately after you came around? Any confusion, weakness?
And I guess getting an account from someone who saw it happen is gold dust, right?
Oh, absolutely critical.
Right.
A witness can describe things you wouldn't know. Did you look pale? Or maybe bluish, cyanotic? Were there any movements like jerking? And crucially, did those movements happen before you collapsed or only after you were already down? That timing is key for differentiating seizure from syncope.
Makes sense. What else is part of that history taking?
You need to know about any other relevant medical conditions the person has, especially heart disease, diabetes, Parkinson's. Family history is vital asking about sudden death, particularly in young relatives. And a detailed drug history is essential. What medications are they on? Cardiovascular drugs, insulin, anything that could affect blood pressure or heart rhythm.
Then comes a physical examination. Even though the person might feel fine now, the exam is still important.
Vital. Often it'll be normal, but you're looking for clues to rule out serious underlying problems. The focus is heavily on the cardiovascular system.
So checking vitals.
Yes, assessing vital signs. And
Yeah.
crucially, measuring blood pressure both lying down and then after standing for a few minutes, checking for that orthostatic hypotension we talked about.
Listening to the heart.
Definitely. Listening carefully for any heart murmurs. And here's an interesting detail our sources mention. The murmur of hypertrophic obstructive cardiomyopathy, HOCM.
The thickened heart muscle one.
Right. That murmur is unusual because it actually gets louder when the patient stands up. Most murmurs get quieter. You also look for other signs like raised pressure in the neck veins, the JVP, or listen for extra heart sounds like an S3 or S4, which can suggest heart failure or thickened heart walls.
And a neurological exam. So
A full neurological check is important, yes. Peripheral nerves, central nervous system. But, as we said, a normal neuroexam doesn't completely rule out a neurological cause, though it makes it less likely to be the primary cause of the blackout itself.
Right.
And you look for evidence of tongue injury, maybe from a seizure, although not finding one doesn't rule out a seizure either.
Okay, so history, exam. Then what about initial tests? What does everyone get?
There are a few basics pretty much everyone should have. A quick bedside blood glucose check helps rule out low blood sugar, hypoglycemia, although it's worth saying fully recovering from a hypoglycemic loss of consciousness without treatment is pretty unlikely.
Right. And the ECG. You mentioned that earlier.
Yeah.
Why is the ECG, the electrocardiogram, so critical even if someone feels totally fine now?
The ECG is absolutely essential. It's looking for underlying cardiac electrical problems that might have caused the blackout, even if they aren't happening right at that moment.
What can it show?
It can pick up so many things. Abnormally long or short QT intervals, which can predispose to dangerous rhythms. Problems with the heart's conduction system, like bundle branch block or heart block. Specific patterns like Brugada syndrome or Wolff-Parkinson-White, WPW syndrome, signs that the heart muscle is thickened, ventricular hypertrophy, or maybe even catch an ongoing arrhythmia. It's a fundamental snapshot of the heart's electrical health.
So a really key test. Anything else initially?
Usually a full blood count, mainly to check the hemoglobin level of the hematocrit, especially if there's any suspicion of anemia or maybe internal bleeding causing the low blood pressure.
Okay. And then based on all that, sometimes more selective tests are needed.
Exactly. If the doctor hears a murmur or suspects heart failure or maybe aortic stenosis based on the exam, then a transthoracic echocardiogram that's an ultrasound of the heart is usually recommended.
And if they suspect a rhythm problem that the initial ECG didn't catch.
Then ambulatory ECG monitoring comes in. That means wearing a portable heart monitor, maybe for 24 hours, maybe longer, sometimes even an implantable loop recorder for very infrequent symptoms. The type depends on how often the person has symptoms.
Right. So after all this detective work, what does it all mean for you, the patient? How do doctors decide, okay, this was likely benign, you can go home, versus, no, this is concerning, you need to stay in the hospital or see a specialist urgently? This sounds like risk stratification.
That's precisely what it is. And the role of the doctor in the emergency department is pivotal here, to quickly sort patients into low risk who can likely be managed safely as an outpatient and high risk who need admission or urgent further investigation.
What makes someone high risk? What are those indicators?
There are scoring systems, like the San Francisco Syncope rule, which is widely used. It flags patients as high risk if they have any of these. A history of congestive heart failure,
See.
a hematocrit less than 30%, an abnormal ECG, a complaint of shortness of breath,
Yeah.
or a systolic blood pressure below 90 when they arrive, so CHESS.
CHS. Okay, that's helpful. Any other guidelines?
Yes, for instance, the NICE guidelines in the UK recommend further assessment or admission for anyone with an abnormal ECG or if the blackout happened during exercise.
Definitely a red flag.
Absolutely. Also, a family history of sudden death under 40 or an inherited heart condition, new or unexplained breathlessness, or if a heart murmur is found on examination.
What about the circumstances of the faint itself?
Other really serious signs include the blackout happening while the person was lying down supine. That's very concerning. Or, as we said, during exercise. Also, a complete lack of any warning symptoms, any prodrome, feeling palpitations right before the event. Or sometimes just being elderly and having syncope without any clear prodrome can be higher risk.
And you mentioned frequency earlier.
Yes, that's a crucial point. If someone starts having blackouts more and more frequently, especially if they have known heart disease, that's an ominous sign. It could mean their underlying condition is getting worse and needs urgent attention.
So conversely, who falls into the low-risk category?
Generally, patients who don't have any of those high-risk features. They're often younger, have few or no other significant medical problems, their physical exam is normal, and crucially, their ECG is normal. These individuals can often be safely discharged home, usually with advice to follow up with their regular doctor.
Okay, so let's say the immediate danger is assessed. Maybe it was deemed low risk or the cause was found and treated. What about life after a blackout? How is it managed long-term, especially the more benign types?
Well, since syncope itself involves spontaneous recovery, the immediate goal in emergency care is really about identifying who's at risk for future problems.
Right.
For the uncomplicated types like vasovagal or situational syncope, the management is mostly about education and reassurance.
Explain what happened.
Exactly. Explaining the mechanism, helping the person identify their likely triggers. Was it standing too long, heat, a specific situation? And advising on strategies to avoid those triggers. And reassuring them that for these types, the prognosis is generally excellent. It's not dangerous in itself.
Just keeping a diary held.
Keeping a symptom record or diary can be really useful, yeah. It helps pinpoint those personal triggers over time.
And for orthostatic hypotension, since that's often more chronic, are there lifestyle changes?
Yes, definitely. For orthostatic hypotension, there are several practical lifestyle changes that can really make a difference.
Like what?
Things like taking a moment to sit on the edge of the bed before standing up fully from lying down. Eating smaller, more frequent meals can help reduce blood pressure drops after eating that's postprandial hypotension.
Okay.
Liberalizing salt intake, unless the person has high blood pressure or heart failure, of course. Drinking strong tea or coffee can sometimes help. Staying well hydrated, aiming for at least 2 liters of water a day. Avoiding alcohol, which can lower blood pressure.
That makes sense. Anything else?
One quite effective technique is tilting the head of the bed up at night. You put blocks, maybe 15 to 22 centimeters high, under the headposts of the bed. This helps the body readjust overnight.
Interesting. Now, a really practical question for many people. After any kind of blackout driving, what are the implications?
That's a huge concern, and rightly so. The rules can be quite strict, and they vary by region, so checking local guidance is essential.
But generally?
Generally, for a single typical vasovagal faint happen while standing, clear prodrome, normal heart exam, normal ECG, you might not need to inform the driving authorities, like the DVLA in the UK or DMV in the US. But that's a very specific scenario.
And for other causes?
For almost all other causes, orthostatic hypotension, suspected cardiac syncope, neurological causes, or even recurrent vasovagal syncope, there are usually mandatory reporting requirements and driving restrictions, often for a set period. It's really crucial to get specific advice and follow the rules. When in doubt, report it.
Absolutely. Safety first. Finally, our sources highlight some important sort of safety pearls or key takeaways for clinicians, but also useful for listeners to be aware of.
Yes, a few key things to always keep in mind. 1, always consider that there might be more than one cause for a blackout, especially in older patients. They might have orthostatic hypotension and a bit of heart block, for instance.
Good point.
2, always assess for injuries sustained during the fall. A blackout itself might be benign, But falling can cause serious harm, like a hip fracture in an elderly person.
Right, the fall itself is a danger.
Exactly. And remember those major red flags we've mentioned. An increasing frequency of blackouts is always worrying. And any syncope that occurs during or immediately after exercise needs urgent medical evaluation. Don't ignore those.
So we've really covered a lot of ground here, navigating the complex world of blackouts from those mostly inconvenient, benign faints right through to potentially life-threatening cardiac conditions. I think the key takeaway from this deep dive has to be the absolute critical importance of getting that detailed history, doing a targeted physical exam, and using essential investigations like the ECG. That's how you start to unravel the underlying cause and figure out the right path forward.
It's truly fascinating, isn't it, how much information our own bodies can give us, even from that brief moment of unconsciousness. If we and our doctors know how to listen and interpret those clues, it can tell us so much about our health.
Absolutely. And maybe a final thought to leave our listeners with. Considering that our sources suggest up to, 50% of syncope cases that show up in the emergency department don't get a definite cause established, even after a pretty thorough workup.
Yes, that's a significant proportion.
What does that tell us about the current limits of our diagnostic understanding? And maybe, where does the next big breakthrough in research need to happen to start unlocking some of those remaining mysteries?